It's my privilege indeed to present the results of this trial to you. It's the acronym for the trial is TAILORx or TAILORx, which is an acronym that stands for Trial Assigning Individualized Options for Treatment. It's the largest adjuvant breast cancer trial or cancer trial ever performed. It was performed in six countries, 4 continents, over 1,100 sites, and includes the 20 co-authors shown here, and a total of 30 co-authors in the publication that will be released later today in the New England Journal of Medicine. So the background for this was that adjuvant chemotherapy is an established therapy for women with early breast cancer. And the rationale for the TAILORx precision medicine trial here is what we were really trying to do is thread the needle. 50% of all breast cancers are estrogen receptor positive or hormone receptor positive, HER2 negative, and node negative, and up to 30% of these patients can have an incurable recurrence by 10 years. Adjuvant chemotherapy is typically recommended, but the benefit, absolute benefit, is small. This results in most patients being overtreated because endocrine therapy alone is adequate, but some are undertreated, and some who did not receive chemotherapy could have benefited from it. The second critical feature is this availability of the gene expression assay, the 21-gene recurrence score. We knew from previous studies that the information provided by this assay was prognostic in the sense that those individuals who had a low recurrence score had a very low risk of recurrence with endocrine therapy alone. And we knew that, or we thought we knew that we can safely spare chemotherapy in those patients. In addition, it was predictive. That is, it showed large chemo benefit when chemotherapy was added to endocrine therapy. But there was a major gap. There was uncertain chemo benefit for patients who had the mid-range score, and this was about 2/3 of all patients who were treated. So the key design elements of TAILORx were that patients were assigned to therapy for a low recurrence score or a high recurrence score, endocrine therapy alone, or chemo plus endocrine therapy. There was a chemo randomization for the mid-range score to determine whether chemo was indeed beneficial. There was an adjustment of the mid-range score, and it was a prospective trial that reflects the most modern chemo treatment. The design and the key elements are shown here. The eligibility included women aged 18 to 75 who had estrogen receptor positive or hormone receptor positive HER2 negative breast cancer. They met established guidelines for chemotherapy. About 10,000 women were registered, and those who had a mid-range recurrence score of 11 to 25 were randomized to the standard arm of endocrine therapy plus chemo versus the experimental arm. The statistical plan was a non-inferiority design, which is a very rigorous type of design to prove that chemo is not beneficial. And the patient characteristics, median age was 55, a third of patients were 50 or under, and the majority of patients had either small tumors or intermediate grade. And standard adjuvant chemotherapy regimens were used, and endocrine therapy regimens were used. And here are the top-line results. For the primary endpoint, shown in the Kaplan-Meier curve on the right, endocrine therapy was non-inferior to endocrine therapy plus chemotherapy. The hazard ratio was 1.08. The 95% confidence intervals did not cross the hazard margin, not statistically significant. The primary trial endpoint was met. The 9-year disease-free survival rates were 83.3% for the endocrine therapy arm, 84.3% for the chemotherapy arm. Other endpoints, similar outcomes. Distant recurrence rates were 5% overall, and overall survival rates were similar at 9 years, irrespective of chemotherapy use. In terms of the other arms, for those who had a low recurrence score, there was a 3% distant recurrence rate with endocrine therapy alone. And for those who had the high recurrence score assigned to chemoendocrine therapy, there was a 13% distant recurrence rate despite chemotherapy and endocrine therapy. And a very important finding was that in an exploratory analysis in the randomized group, which we conducted to really nail down and determine whether there was, to make sure there was no subgroup who derived some benefit from chemotherapy, we found an interaction between age and recurrence score. So the younger woman, 50 or younger, who had a recurrence score of 16 to 25, had some chemo benefit. And there were 2% fewer recurrences for a recurrence score of 16 to 20, and 6 to 7% for those with a recurrence score of 21 to 25. And this is information that could drive some women, younger women who have a recurrence score in this range to accept chemotherapy. So in terms of the big picture and the impact on care, application of this test in clinical practice to this population would be estimated to spare chemotherapy in about 70% and to select chemotherapy in about 30% on average. Thank you for your attention.